Let us now start with workup of squint. So a patient has entered your OPD and you have to check for squint and your workup on that line. What are the things you're going to ask him? So first is history. We'll ask him about since when he has got this deviation. If the deviation is manifest, of course, then only we can ask these questions in the history. Since what is this deviation for, since what time it is, why it is important to know the time. As you know, concomitant are more happening in the early stages than in concomitant. Secondly, we have to also know about, is it constant or intermittent? So suppose there is a constant squint, there can be problem of amblyopia. I've explained you, right? If there is no foveal fixation. Or is it inconstant, means intermittent. Intermittent squints, amblyopia may not be a problem. Okay, so give the heading squint workup. Let's start. The workup of squint, first thing you have to know is the history taking. Now, history taking can be very elaborate, but that has to be read at the PG level. But we'll just have a brisk idea. We are talking about the deviation. What is the time of deviation? Whether the deviation is, as I said, is it a constant or is it intermittent? What else I can ask? I can ask about diplopia, right? Whether this patient has diplopia, any double vision in any gaze, right? Then we can also ask about any typical head posture. We can, of course, during examination, we will be looking at the head posture. We can ask it also, as well as very, very important, and of course, specs, whether he is using specs, since what time he is using, what is the number he is using, all this is going to give us the idea for his refractor status. And very important in any history taking for squint is to see and ask for old photographs. Okay, so we will ask for old photographs so that we can compare with the present. Now we talk about the on examination and what is asked at our level. We are now going to talk about that. So when the patient has come to me and I'm examining the patient, you are going to learn with me now. So be alert. And we are going to think from outside to in. First, we are going to look at his head posture, number one. Once we have seen the head posture, the next thing that we will see is ocular alignment and then ocular movements. These two should be the series. So first I am going to next check for ocular alignment, right? Ocular alignment, as we mean to say that is it normal or there is a squint, right? So checking for ocular alignment, whether there is a squint or not. How do you do that? We'll come to this later. Just first write down. So this ocular alignment, then we have to talk about is, second is ocular movements. Now ocular movements we have discussed in so much of the details. Single eye movements, adductions, and when the two eyes moving together, what are these? These are the versions. We have talked about yoke muscles. So we have to see all types of ocular movements. Just quickly note down. We will see the adductions. We are going to see the versions, right? In all the 9 gazes, all 9 gazes, and another important thing, for far and near. All 9 gazes for far and near. And what is the third type of movement I can check? Is the vergence. What is vergence? When two eyes are moving in opposite direction, that is convergence and divergence. And how do we check the convergence? Do you all remember? RAF rule, right? We find out what is the near point of convergence. How do you find it out? I showed you how the patient is going to fix at the small box at this, on the ruler, is going to bring it nearer to his eye. And the point where the patient sees double is the near point of convergence, right? So wherever he sees blurred is the near point of accommodation. Wherever he sees double, it is the near point of convergence. I hope it's clear. So we are going to check for near point of convergence, and we will, what is the normal value? It is 10 centimeters. More than that, even we can see double, okay? If you take it more closer, right? Anyway, so we have checked the ocular alignment is normal or not normal. We are saying we are checking the ocular movements, which will give us the idea what type of squint it is. Anything else? Of course, for visual acuity, what is the vision in the patient? We are going to talk about, we will have to do the refraction to see whether we can correct it, this vision to 6/6, or we cannot. Very, very important, right? After that, once we have done all these basics, we have to go for a detailed anterior segment examination, right? Because any problem, any opaque media can also lead to squint, right? So any disease leading to squint, that is why it is called secondary squints. So those squints are secondary. So anterior segment detailed examination. उसके बाद Of course, that should also include your ptosis hai ki nahi. So we will check for ptosis. Then we should also, what is the role of pupils? As you know, fixed dilated pupil in third nerve palsy. So pupils should be particularly seen nicely. Anyway, this comes under anterior segment examination. And after that, we go for posterior segment, isn't it? Any problem in the fovea can also be a cause of squint. So any problem in the central retina can be cause of squint. So we will do the posterior segment examination in detail. Now, when you say posterior segment, we can also check for foveal fixation. So how do we do that? So what happens is in the direct ophthalmoscope, when you're rotating the knob, there will be one star which is projected. Normally we see with the normal light and the normal aperture. So when that star is projected on the retina, that should fall almost within 2 degrees of the fovea. So if you ask the patient to look in the light, so if the star is just at the fovea within 2 degrees, it is a central fixation. But if it is away 2 to 5 degrees, then it is a parafoveal fixation. It is not foveal fixation, it is parafoveal fixation. So this posterior segment, of course, you are checking for any pathology. So check for any pathology. And after checking for any pathology, what is the next thing we are doing? We are also checking the foveal fixation. Whether it is foveal fixation or it is parafoveal. When do you say parafoveal? What did I just tell you? It should be 2 to 5 degrees away from center, right? From the center. So how do we do that? Should I repeat? I just said the star from the direct ophthalmoscope is projected and the patient is asked to look at it. If it is falling at the center, then it is a foveal fixation. Otherwise, it is not. Anyway, after we have done all this in all 9 gazes, far and near, we should also very quickly also see the oculocephalic reflex. Don't forget that. Right? You can check that as well. Now, after doing all this, what is the next thing we have to go for is, though I have told you practically the purpose of oculocephalic reflex is more in relation with the comatose patients, but yes, you have to know this and you should know whether it is normal here or not. Once we have done all this, simple, nothing is difficult till now. Na? See, it is going to be easier now. So once we know this, we come back to the point ocular alignment. So our first question is whether there is any squint or not. So if it is manifest, even then you have to be 100% sure, or it may even be a latent squint. So our next question for this patient to work up for the patient is, we have to answer this question whether there is squint or not. Now, and very simple, there will be 2 tests which I do which is going to confirm this. One is called cover test. So we generally call cover and cover together. Do you know why we call it together? It has become a protocol to call it together because after cover, if everything is normal in the cover test, we go for uncover test. So very quickly we generally say cover uncover test. But actually cover test is different, uncover test is different. Chalo, samajhte. So first we go for cover test. Okay? This will be my first step. Now what is a cover test? Now cover test is the same which I explained you when I was explaining you about primary and secondary deviation. Very quickly going back to my simple example, if these are the 2 eyes, this is the squinted eye. I cover the normal eye and see the movement of the squinted eye, right? If it takes the fixation, this is deviated behind the cover. This is your primary deviation. When I cover this eye, this takes the center, this deviates, this is your secondary deviation. Now, cover test, okay, let's think like this. If the 2 eyes are straight and ocular alignment is normal, then when you cover this eye, nothing is happening. Now, there is no movement. You get my point? So, if there is no movement, there is no squint. It is normal. But if there is a movement, so what movement it can be? So, I'm going to show you a video after this, so have patience. So, what movement it can be depends. So, in this example, I said this eye is divergent, so it will come in. So, if it is coming in, I know it was out. If it was coming out, if it is going out, I know it is in. So, this way I can know that, okay, this is the deviation in the eye. And especially it is challenging and important because when there are small deviations. So, we are going to be very, very clear about it while we are watching this video. Okay, so let us see. I will keep explaining. Watch this video, please. So, talking about this cover test, if you see these are the 2 eyes, I think it is straight. I can see the eye reflex straight. So, this is a normal ocular alignment. I cover one eye, there is no movement in the other eye. Now, I cover the other eye also. No movement, correct? This is what is So this is telling me that it is normal. Now I cover the other eye. See, no movement. This is what is your normal ocular alignment. This is seen. If it is a normal ocular alignment, this will be the finding. Can we see that the left eye is esotropia? Eye is in. Now I cover this eye. Eye goes out. Correct? And can you see the secondary deviation in the right eye? If I cover the squinted eye, nothing happens to the normal eye. Let us again see this so that we are absolutely clear. So in this case, what do you see? You are seeing that this patient has left eye is inward. Now, what is this deviation in the left eye of the patient? This is primary deviation. Now I close the eye goes out, and look at the right eye. This is secondary deviation behind the cover, which I could find out. Is it clear now? Okay. Now we come to the next example of what you are going to see in exotropia. Can you realize here left eye is out in this patient? Now this is primary deviation of the left eye. Now we cover the right eye. Once we cover the right eye, the left eye comes straight in, toward in. When it comes in, that means the eye was out. Look at the secondary deviation of the right eye. And once you remove it, again the right eye will take the foveal fixation. Okay? Now it is absolutely clear. Now see the vertical squint. Look at this vertical squint. What do you see here? We see, if you see carefully, the left eye is hypertropic, and you can also see the compensatory opposite head tilt to take care of the intorsion defects, right? So this is a case of esopalsy, and you can see the left eye is hypertropic. Now what we are going to do? We are going to cover the right eye. Let's see. What happens? Look at the left eye, it will come down. Yes. Very slight movement, but it comes down, right? So, but when this is what now see, what happens if I am covering the squinted eye? Nothing is happening. Got it? So, if once you have watched this video and you are absolutely clear what is a cover test, what do you actually see in a cover test is movement of uncovered eye. Keep this in mind. So, what we are looking out here in a cover test is what is the movement of uncovered eye. And of course, it will always be opposite to the squint. Do you understand that? Don't mug it up. If it is esotropia and you have covered, naturally the eye, if it has to take the central fixation, it will come out. Na? So if on cover test, you see an outward movement, it means what? Squint was inside, eye was inside, right? If you see an inward movement, means eye was outside, right? So it is whatever movement you see, squint will be, the type of squint is opposite. The movement is always opposite to the type of squint. What we mean to say here, if it is an exotropia, what we will see on covering, eye goes in. So movement is in. In esotropia, movement was out. And in hypertropia, movement will be down. Simple, common sense, right? So whenever it has to take the central or foveal fixation, it will move in the opposite direction. And I think now you are absolutely clear what was primary deviation, deviation of squinted eye. What is secondary deviation? Deviation of normal eye behind the cover. So now you will not ask, why? How can I see behind the cover? We could see it while removing the cover. Okay, this one is the secondary deviation. It takes few seconds. So it is waiting for us to see, right? Yeah. So this was your cover test. Now suppose it was normal ocular alignment and the cover test is normal. So if the cover test is normal, what next? I will next go if cover test is normal. Then in this patient, there is no manifest squint. So cover test tests what? It tests manifest squint. Another point. Okay? Now, if there is no manifest squint, still shouldn't I look for latent squint? Yes. For that, I will do second step is, this is my second step, that let me go for uncover test. Before I again show you the video of uncover test, pay attention. You have to understand, in uncovered test, we are looking at the eye while uncovering it. Means in cover test, it was on the uncovered eye. If I have covered here, I am looking at the movement of this eye. Whereas in uncover, I have to look at the movement of the same eye which is under the cover, but while uncovering it. So I am now more focused on this eye while uncovering it. Got it? So we see movement of the covered eye while uncovering it. And suppose you are not, and there is another method that sometimes occluders can be translucent and you can see through it also. Okay? But generally we use these occluders and we just watch while uncovering it. What is uncover test? Let us see. And this second point also, this will, and of course it will be the same rule. If there is an inward movement, it was out. Outward movement, it was in. So again, the thing is same. Only thing you have to remember that uncover test is to check forias. Please note down, to check forias, that is your latent squint. Forias, that is latent squint. Okay? Chalo. Okay, so it's already written, look for the movement as the eye is uncovered. Be careful, okay? See. So in this patient, once you uncover it, look at the movement, it comes out. Uncover it, it is coming out. If it is coming out means it was going, it was in, isn't it? So while uncovering, when you are seeing it coming out, this is what is, and as it is repeated, you see that in this patient, the left eye is showing more prominent movement than the right eye, right? So this is what is latent squint. And why did it happen? Because I have broken the fusion reflex. So what we are doing, we are breaking the fusion reflex. Is it now clear? That means if there was no latent squint, you will not see any movement. And if it is, as in this case, it was coming out, that means the eye was in. If it had been coming in, it was the eye was out. So in this case, the video that saw where it was coming out, that means it was should I say tropia or phoria? Phoria, we are talking about latent squint. So actually the role of cover here, it breaks, you can note down, the fusion reflex. Therefore, this is manifested. Okay. So no movement in normal circumstance. If normal eye, then no movement. Okay? Simple. So the movement will always be opposite to the squint. I think it's easy. We next talk about after this. Now I know whether it's a latent or manifest squint, right? I know it is squint. Suppose it is a squint. And I could get a finding on the cover test. If I could get a finding on the cover test and I know there is a squint, what is my next step? How much is the squint? So my next question would be, if cover test is positive here, suppose cover test or uncover test, whatever is positive, we have to next go for amount of squint. So cover test or uncover test if positive, then we have to go for amount of squint. Check the amount of squint. Now, how do you check the amount of squint? Before I go into it, I want to remind you all, I just mentioned this. How do you denote the amount of squint? Either in degrees or in prism diopters. And very simple, prism diopter is almost double of the degrees, right? So 5 degrees may not be exact, but almost 5 degrees means 10 prism diopters, something like this. So keep this in mind. Okay, so once we know this, now how to know how much is the squint? One is your very rough method. The patient has come to me, I'm showing the torchlight in front of his eye. And what I'm trying to do, let's see here, draw this diagram before I show you the slide. So what I'm trying to do is, I am trying to find the location of the reflex when I show the light in front of his eye. So we had already talked about this, that normally the reflex is slight nasal. That's the normal position. Okay, suppose this is the normal position. Now, because we all have small positive angle couple, we have talked about all that. Suppose the patient has the reflex which is more towards the pupillary border, right? So if it is at the pupillary border, how much it is? So as around 18 to 20 degrees. If the reflex is between the limbus and the pupillary border, it is around 35. So this is a rough estimation. And if it is at the limbus, now the squint is 45 degrees. Now, inner border of pupil, it says 18 degrees. Outer border of pupil can be 20 degrees. Now, your sources you may see some variation in these degrees according to wherever you see. There can be some differences mentioned, 18 or 20. At some places you may find 25. Now, what is more important is, let's learn this one. And what is more important is to know this is how you're seeing we are having the rough estimation whether there is squint or not, isn't it? It's more like a qualitative thing, not exact measurement. What is this test known as? This is what is called Hirschberg's test. Okay, So this is what is Hirschberg test. So if the patient has come to me, I'm showing the torchlight and I'm seeing cover and cover and I'm seeing the light reflex. I know majority of the time we know very quickly there is a squint or not. Now, once we know this, but this is just a rough estimation, we would like to exactly measure it, isn't it? Achha, before that, there's another way of, in a small child, a small infant, and you want to know whether there's a squint or not, you should be familiar with this test. We call it Bruckner test. It can be done in bigger children, of course, as well, but helpful for the infants. Bruckner's test is, normally when you show light to the eye, what happens? The light reflects, the fundus is shining equally in both eyes. But if you see one reflects brighter than the other, I'll just show you the slide, then the brighter one will be that of a squinted. So the brighter reflex means there is a squint here. And the normal or dull reflex is normal. So the dull reflex is actually normal and the bright reflex means there is a squint. Shall we see first? Okay, so this was your Hirschberg test. So what do you see here? Very much a common sense, all of you. I just told you about the displacement, correct? It is not at the center, it is displaced. So one more thing you have to remember, that 1 millimeter of displacement amounts to around 7 degrees of squint. Please note it down. I am writing here only 1 millimeter of displacement is around 7 degrees of squint. Now, do you realize something? If the eye is inward, the reflex will fall outward. It's always opposite. Just like the cover and curve test. If the eye is outward, the reflex is going inwards. So simple, right? So this is what you have to understand. And of course, see in this case, let's see what they're trying to show here. This is normal alignment, no squint. Okay? You can see this, the reflexes are slightly nasal and this is normal. What is the reflex I'm talking about? The light that is shining on the cornea. I'm talking about this white gola. Okay, here this one. This is what is we are talking about, this reflex. Okay, this is what is light reflex. Now look at this one. Because the patient's left eye is inward deviated, this reflex is outward deviated. Outward, it is going outward because the eye is coming in. The eye is in and therefore the reflex here is outward. And if I see here, it is almost at the pupillary border, 18 to 20 degrees of squint. Now look at this one. Now it has shifted to 30. Please learn 35, not 30. We will learn 35, right? So let's learn 35 degrees. And of course, when it is at the limbus, this is called, that will be around 45 degrees. So this is what is Hirschberg test. But what is very important, you should know 1 millimeter. If this is the normal, 1 millimeter deviation means amounts to 7 degrees of squint, which is around 14 to 15 prism diopters. Prism diopters हम लोग या तो PD लिखते हैं और we make a prism and we like a D. This is also prism diopter. Okay. Now we come to Bruckner test. So this is what is Bruckner test. This seems to be normal to me, but this is too bright and shiny. This is the squinted eye. So it's a very rough thing. Just to know squint hai, nahi hai. Is it there or not there? That's it. It will answer only this much. Okay. We come to the third method. I hope you're noting down how to know the amount of squint. Okay. So we had an idea of about Bruckner test is telling only about the presence of squint, but amount of squint, yes. One is your Hirschberg test. Second is, let's now measure it exactly. How to do that? Do it with the prisms. So we go for, okay. So what is, next heading is what is prism cover test? We in short write it as PCT. Do the same cover test that you're doing. Look at the movement of the uncovered eye. But this time when you're doing that, you are also putting the prism of different strength. So this is like a scale with different strength of prism. We call it prism bar. If there are different prisms in the same scale, we call it prism bar. Pay attention. Look at me. What is the amount of prism in prism diopters at which there is no movement in the cover test? समझ आया? At what prism diopter there is no movement in the cover test will be the exact amount of squint. This is what is PCT. Can you write it with me? So, in what prism diopter there is no movement on cover test. That will be the exact amount of squint. Now, there is one trick here. What you have to understand, how to place the prism. Prism has an apex, prism has a base. Please remember, base is always opposite to direction of squint. Can we do this? Can we understand this well? So when you say base is opposite, okay? So when the base is opposite means if this patient has esotropia, I want to know how much amount of this inward deviation or esotropia. क्या करूंगी मैं? Base out. I am going to put a base out prism and try to check for the amount of squint. Similarly, if this patient is exotropia, I am going to put a base in and then check the amount of squint. Okay? So just remember this, that what prism diopter the patient has no movement on cover test is prism cover test. What are the other methods? There is one more, that is called reflection test. When you say reflection test, look at this one. Look at the first slide. What do you see in the first slide? What we see is that the right eye is inward deviated. Look at the light reflex. Quick Hirschberg test, if you see there, the light reflex is at the center. Here it is almost at the pupillary border. It is out. Why it is out? Because eye is in. Now when the eye is in, what I am doing? I am putting a base out, apex in, base out prism in front of the squinted eye, and I keep seeing the behavior of normal eye. What I am doing is I am putting the prism and seeing at what prism strength the two light reflexes center. Okay, please correct this. So this is what is prism reflection. So based on the Hirschberg test, you can see in the first slide आप क्या देख रहे हो? The left eye is center, right eye it is deviated. Now you have placed that prism strength so that both reflexes are coming in the center. So write down, this is called prism reflection test. Note down all of you in that only, that what prism strength, what prism diopter, both eye corneal reflex is at the center. Is at the center. Okay, so this is what is your prism reflection. And you know what is Krimsky's test? Actually, this is not exact. Krimsky means when the same, you can put this prism on the normal eye, in front of normal eye, and also check. It is okay. So if I am doing this, that I am putting the prism on the normal eye and then checking the same thing, what prism diopter, the two light reflexes are at the center, अब उसको बुलाते हैं Krimsky. But for you at your level, actually this is used synonymously. You can call it so. Okay, let's not be very microscopic. Okay, it's not difficult to retain this, that if I'm using the same prism, the same test, but instead of the squinted eye, this time I put the prism in front of normal eye. Right? This is what is Krimsky. Okay, is there any other method? Of course there is. So this was the Krimsky test, which means, as you can see, this is the normal eye and I'm putting the prism. So because this is base, what do you see? If this is the reflex is out here, it is showing that the reflex is out, that means eye is in. If eye is in, what should be the prism base? Out. It should be opposite. This time I am putting in front of the normal eye and I am seeing at which prism strength the two reflexes are at the center. Clear ho gaya? So this is what is Krimsky. This is the prism bar again for you all, how we test it. This is what is happening here is prism cover test. Again, this is prism cover test. At what prism? There is no movement. Okay, come to the next method. This is by synaptophore. You have already written the uses of amblyoscope or synaptophore in the optics chapter. I'm not going to repeat that. Just remember, synaptophore is going to tell me the squint, right? It is also called amblyoscope. You must have seen this instrument at every eye OPD. You have this instrument. These are the two eyepieces where this is the chin rest where the patient is resting his chin. And these are the two eyepieces through which he sees. Now this is the place where we put the different slides, right? And this, can you see the handle? It can be actually rotated like this also. So all these things are helping us to find out many things. So synaptophore has many roles. I've already taught you that it will not only tell you the angle of squint, right? Amount of squint or angle of squint, how much is the squint. It is also helpful to tell you what are the grades of binocular single vision this patient has. It can help you to improve those grades with optic exercises, but only if your patient is within 8 years of age, right? And then it can also tell you about, it can also help in convergence exercises. Just remember all this, right? Yeah. So this was about, so again, when you're putting two slides and you are trying to find out, so this is the amount of squint. So you can call it differential image method, okay, where you are creating two images and you are trying to work on it. So this is synaptophore. Is there any other method to check the amount of squint? Chalo, I'm teaching in a story form, so let it be in that story form. That okay, you now know there's a squint, you have checked the amount of squint, but this is one case. The another scenario could be the cover test was normal, right? And now you feel that there is a very small degree of phoria can be a possibility. You think, okay, there is a phoria, or it could be so small that even uncovered test is not able to catch hold of. Think this scenario. So there can be some subjective tests up to now. So you will cover this prism cover test and Krimsky, these are all objective. So coming to some other tests, one is, as you can see this, Maddox rod. Okay? Where is the Maddox rod role is? When you are doubting a very small amount of phoria which you are not able to catch by uncovered test. This can also be caused as Maddox rod test, Maddox rod and Maddox vein, right? Two things. So we will learn about that to catch for small degrees of phorias. This is again the differential image test. Different images in the two wells, right? So this is mainly we will be talking about. This is a subjective test. That means it will all depend on the patient's response. So this is your Maddox rod and this is your Maddox. Of course, differential image is actually mainly what we are trying to do here. Let me explain. This is all based, we are trying to create artificial diplopia for the patient. So it is based on diplopia principle. You already know about diplopia, what are the types, what is cross, what is uncrossed, correct? So now we can move further and understand about the Maddox rod and Maddox vein. Okay. So what is the Maddox rod? Maddox rod, as you can see here, is mainly red colored and series of plano-convex lenses. These are cylindrical lenses, right? In front of the eye, right eye, this patient, we have put this lens, correct? Now, so the patient is shown a spot of light. And once he's shown this spot of light, now this rod or this lens is put in front of one eye. What happens? From his right eye, if I'm putting the Maddox rod here, he will see a line of light. And from his left eye, he's seeing the spot of light. This is his right eye, this is his left eye. Now, if the line of light, and because if you see this rod is placed horizontally, therefore here the line of light will be vertical. From the left eye, he will see the normal spot of light. Correct? Now all my inference will depend on what patient responds. That is why it's a subjective test. I'm going to ask him, so did you understand what you have done? You have created one image which is a line and one is already a spot. If there are so much difference, differential image test isliye bolte hain na, because there are two different images, naturally this cannot fuse. And because it cannot fuse, it is leading to diplopia. So you have created artificial diplopia. After that, you ask the patient, what can you see? If he is normal, he will say, okay, I see the line of the light. So, and this is the spot of light which is crossing the line of light, right? So what the patient is seeing, we have to comment on what he is seeing. So this is orthophoria. We are checking the latent squint. Now suppose the patient says that the line of light is left to the spot of light. In this case, see, white is written right means it is line is seen by the right eye in this patient, and this is the spot of light seen from the left eye. Alignment is this line of light is left to the spot of light. It is crossed. Cross diplopia seen in exo. So this patient has exo. But if the line of light is right side towards the same side and the spot of light is here, now this is what is, that means uncrossed. This is an uncrossed diplopia. Uncrossed diplopia means it's an esophoria. This is cross diplopia. This is exo. Okay? This is what is Maddox rod. This is what will help us. This will help us to catch the small amount of latent phorias as well. What is important? This Maddox rod is done for far vision. 6 meter distance. Okay. Now if I have to do it for near vision, then we use wing. Let's see. So this is a Maddox wing. What you do here, the patient is looking through these two eyepieces from this place, and there is a divider. Can you look at the divider here? So this divider, what is this divider doing? This divider is actually dividing that what is seen by the right eye is different and left eye is different. Situation is, if you look at this chart, there are numbers. Vertical red nails, horizontal in white, and there are arrows. Right eye can only see arrows, left eye can only see numbers. Note it down. So in a Maddox wing, we all generally get confused. I'm telling you, right eye only arrows and left eye numbers. Okay? If this patient is almost normal, and you have to just ask him, your arrow, red, both arrows. See, red arrow for the vertical and white arrow for horizontal. You have to ask him which number the white and red arrows are pointing. This is it. If the patient says this white arrow is, he's using some numbers on this side, same side, right? Then what it is? Same side, uncrossed. Uncrossed means it is esophoria. That is why anything on the right side when he says, it means it is eso, if the arrow is right. If this arrow, white one, he is commenting somewhere here, it means it is crossed. So any numbers commented here means it is exo. Easy? Now we talk about vertical. Vertical squint has cross diplopia, I have told you. So if the red arrow is pointed upwards, do you realize arrow is seen by right eye only, right? If it is pointed upwards, means right eye is, tell me, hypo, है ना? But if right eye is hypo, don't we say left hyper? Because the protocol is to mention the eye which is up. Hence it is written left hyperphoria. But if the red arrow is pointed lower, is pointed on lower numbers. Lower numbers means right eye is up. So it is saying it is right hyperphoria. So the lower numbers, right hyper, upper numbers, that is why we say left hyper, but it means right hypo. You can write it here so that you don't get confused. Initially when I was a student, I used to get confused. Where is this left eye came from? So it is right hyper, so means it is left, right hypo means left hyper. Okay? And this was ESO and this is there. Even the torsion can be checked. In torsion and extorsion, there is another arrow for that. We will not go into that detail, just understand this much. Right? So that was about your Maddox wing. So Maddox wing is same principle. Diplopia, creating diplopia, it is on the diplopia principle, but for near vision. Okay, differential image test for near vision. Okay. Now we talk about another subjective test. So, up to this point, the questions have come on, of course, have come on Maddox rod, Maddox wing. Okay, we were talking about torsion, right? So, in torsion, extorsion, what is the best way of knowing the torsion and of the eye and what is the amount of torsion? We'll discuss this also. We'll discuss this. This is your double Maddox rod test. Ye kya cheez hai? Double Maddox rod is nothing but I am putting the Maddox rod in both eyes. Okay. If I put the Maddox rod like vertically, like this in both eyes, what happens? The patient sees horizontal lines, isn't it? Now, what will happen if there is a torsion? That one line is, ideally it should be parallel. Both the lines should be seen parallel. This is normal. But if one is tilted like this, now you will move the corrective lens and see amount of, so this movement of corrective lens is done in cyclotorsion or in cyclotorsion till both the lines become parallel. So what is the amount of correction that is needed in the lens to make the two lines parallel, the corrective lens? That is what is double Maddox rod. It helps us to catch the torsion and amount of torsion. How much is the torsion? And what is the torsional squints generally are seen like this. Okay. And what is the amount will depend upon how much I could rotate it. Right. 3 degrees to 7 degrees, anything like this. right? And we'll keep this in mind. So this is very helpful to see the assess the superior oblique palsy, right? So this what are we talking about? Rotation of the corrective lenses, right? The cylindrical lens that we are using to correct to see how much we have to rotate in order to make the two lines parallel, right? Okay. But this test, it will not differentiate between fovea and tropias. Yeah. Now, another very subjective test, only once this question has been asked to you all, there's another subjective test which is based on haploscopic principle. Now, what does haploscopic means? In diplopia, what was happening? There's one location, but there are two locali. One ka two dikh raha hai. Now, haploscopic means there are two locations and you have to make it one localization. Okay. So, based on haploscopic principle, this test is done in concomitant squints. Okay, in concomitant squints. So, in concomitant squints, we have learnt how the palsy of muscle is leading to what sequelae. So, all that can be nicely charted. What is the name of the test? It is called Hess screen. So, either we can say Hess screen or Lee screen. We'll talk about it quickly. So, this helps us, and please remember that all this is based on foveal projection, which means whatever I am going to see in the chart, in the Hess chart, is as such actually estimated. We don't make it opposite just like for diplopia. Okay, let me first explain this Hess chart, then you will understand what I am trying to say. So in Hess screen, the patient is wearing red-green goggles. Okay, and this, first of all, suppose the red goggle is in front of the right, the red lens, and the left is green. What we have to understand, he's seated 50 centimeters from a screen and he has an indicator in his hand, which is the green light. Okay? So now you have to understand, we are testing the eye where there is green. So red is only acting as a fixator and green is the indicator where you. So what we are doing? The procedure is, the patient is 50 centimeters from the screen here. Right, one eye, red-green glass, first time the green is on the left, suppose. Then he is testing, what are you doing here? Listen, red light is being projected on the lens and he is asked to locate where that red light is, wherever it is on. So either the patient has that, the examiner has that red pointer and he is checking, or in this case, it can be just electronically operated. So, if I am the patient, what I have to do? By wearing the glass, holding this, I am just matching my green light and going and telling, okay, this is the red spot. Okay, I will match my green spot to this red spot. Now the red spot is here. I match my green spot to this red spot. Now it is this. Got it? So now once I have done for this eye, I will change the glasses. Now my green is in front of right eye. Right? And please remember, wherever the green glass is, I am testing that eye. So what happens? What happens is, this is the Hess chart and there was only one question for you and this was asked, what is this chart known as? That was the only basic question. But it's very simple and interesting. Let's see this. This chart has these squares. Each square is 5 degrees. You should know this. Now this inward green, as you see, the little bigger square is 15 degrees and the out purple one is 30 degrees. Okay? Now I can only concentrate on green, or I can concentrate on purple. If I see that, okay, I cannot catch much on the smaller field charting, I can go up to 30-degree charting, which means what? Kuch nahi. It simply means the red light which I was showing, suppose, see, I am doing it for you here. Suppose I was the patient. First I showed the red light at the center. He has to fix his eye here. Okay? Now suppose the red was at the right eye, he is fixing it with. Now there's, okay, one red light has been on here. So I will put my green here, then it is here, okay, here, here. So when I am doing at different locations like this and the patient is putting that green over that. Okay, this is the test. Now what happens? I can also chart in a bigger field like 30 degrees. What do you think these muscles indicate? Go back to your yoke muscles. If this is the chart and if I say left eye and right eye, and okay, let's see something like this. I'm going back to our basic this diagram. Okay? So you know that okay, this action is denoted by, if this was a right side, this is lateral rectus. This action is denoted by medial rectus. This one will be denoted by inferior oblique, superior oblique. Then this is the superior rectus, and this is the inferior rectus of right. We remember all this now? Abducted eye, elevation and depression for right eye, adducted eye, it is oblique. So this is what you have to keep in mind, and they have labeled the different muscles out here at these locations. Correct? Now you change the eye, change the lens, go for the other eye and chart it. What can be the findings? This is depicted somewhere like this. Suppose we take an example of this condition. What do you see in this condition here? What do we see here? All of you? Okay, whatever small it is written labeled is nothing but the name of the muscles. So what we see overall which? So please remember, it is directly indicating the action. It's a foveal projection. That means if this is the left eye, we are talking this temporal, this is the left lateral rectus. This will be the left eye medial rectus. Okay? Left medial rectus action is shown here. Then this will be your right lateral rectus action. So what do you see here? We see that we are charting. Normally, whatever should be the charting should be in this line. Dotted is shown here. If he was normal. In the bigger chart, if I look here. But here, the line, green line is involved. Right lateral rectus under action. And because of that, left medial rectus, this is all over action. You see, it should have stopped somewhere here. Isn't it? But it is coming up to here. So, this way, we are able to, so first of all, we quickly look at, okay, which field is looking smaller. That is the affected eye. So, here right eye is looking smaller. What is the problem? We see that the lateral rectus is not working properly under action, right? And we also have to see whether centrally the fixation is correct or not correct. And accordingly, we can just think yourself, what was the sequelae of a muscle, overaction of the yoke muscle, then the contracture of the ipsi. So, all that can be slowly with time charted on the Hess chart. Right? So, this is just an example of your right lateral rectus palsy, and due to that, there is a left medial rectus overaction. Nothing more you should know. We come to the next, what was Lee's screen? Exactly same thing, right? This time, instead of red-green goggles, this differential image test, red-green goggles, but this time, of course, but this is based on haploscopic principle. Just remember that. There is a mirror here. Okay, can you see this mirror here? This one. This is separating, so the right eye can see this screen, left eye seeing this screen. Now what happens? How does the left eye see when the right eye is focusing here? It is depicted by the mirror. The mirror reflects the image. The image is reflected on the mirror, and the patient is actually seeing that. And according to that location, she is putting the points where whatever she is seeing on the mirror, the screen that is reflected there. Accordingly, whatever spot is asked, she is trying to overlap with the spot on the other screen. So actually, it is based on the same thing. Just remember, this is what is called Lee screen. I just want you to be familiar with the name. This is Lee screen. Okay, so once one is illuminated, then the other is illuminated. Alternate illumination, beech mein mirror hai, dono eye we test like this, both eyes, right? Yeah. Okay, so that was about the different tests. I think now squint workup, everything is very clear. A very quick brief here. After taking the history, we have seen the ocular alignment. After we have seen the ocular alignment and how we confirm the ocular alignment, whether there is squint or not, by cover test. If that is normal, we do uncover test. Okay, and what is the alternate cover test? Again, when the uncover, again the second video which was you saw, one I'm covering this side. It can also be called alternate cover test. Okay, and then after this, I know the ocular alignment, whatever it is. Of course, I will test the ocular movements, the ductions, versions, and vergence. I should know the refractive status of the patient. I should know the visual acuity, and of course, detailed anterior segment and posterior segment examination. And once I know that I have done all this and I am very clear whether the foveal fixation is there or parafoveal fixation is there, what next? We will measure the squint if we find that, okay, there is a squint. In that case, how do you measure it? We measure it with the prisms. Base is always kept opposite. It's a very simple method. Exo and ESO, accordingly, base opposite, we will measure. What are the tests? Either we do the cover test with the prism and try to find out which prism there is no movement in the other eye, uncovered eye, right? That is called prism cover test. Which prism the two reflexes are at the center, that is called prism reflection test. And it can also be called Krimsky test when the prism is placed on the normal eye. What else? We can also measure through synaptophore, right? And then we will not forget, if we feel that, okay, there is a latent squint and I'm not able to catch by the uncover test, I can go for differential image test, that is your Maddox rod, Maddox wing. Maddox rod is for the far and wing is for the near. I think it's clear to you all. And if it is a case of paralytic squints, concomitant squints, another important investigation is based on the haploscopic principle, Hess screen and Lee screen. Right? And if you want to know the torsion, what did we learn? Double Maddox. I think we have missed to discuss one more thing. When you talk about the Maddox rod, suppose in the same example, if suppose I say this is the right eye of the patient, left eye of the patient, and this time the rod was placed like this, vertically. Right? So, this is how we will assess the vertical squints. If the rod in the right eye is vertical and this eye is only seeing the spot of light, in this eye you will see a horizontal line now. It is always opposite. So, now for vertical squints, this is how you will change the alignment of the Maddox rod. Now, what you do? The patient is seeing horizontal and with the left spot of light. If he says, okay, the line is passing through this becomes normal. Right? And if he says, no, the line is below, means the right eye will be up because the line is through the right eye. So, this shows your right hyperphoria. Right? And if now the spot of light is here and the line is above, this is the next finding. If the line is above, this means the right eye is below. So, I will not say right hypo, I will say left hyper. You remember? Hyperphoria. So, this was for the vertical squint. So, these are the quick tests that we do. I think now workup of squint is absolutely very easy for you all and there is no more anxiety around it. Right. What are you looking here? Again, we are trying to test the near point of accommodation and near point of convergence in this child with when she sees double and when she sees blood. Lastly, what is you have to know, there was a question here about oculocardiac reflex. So the question was that you're operating a case of squint and the child starts developing bradycardia. What should be your next step? So please remember what is oculocardiac reflex. If you want to write, please note it down. What happens when we are pulling the muscle? When you pull the muscle, the reflex from the trigeminal through the ciliary ganglion, of course, short ciliary nerve, ciliary ganglion, right? It is finally coming to the fifth nerve. It is going to trigeminal ganglion. Okay? Now, the impulse, the stimulation of the muscle, from the muscle, it is finally coming from trigeminal. Trigeminal, that is the fifth nerve, is the afferent, just keep that in mind, but through the ciliary ganglion. From there, it is going to where? It will come to the vagus, motor nucleus of vagus nerve, and you know what vagus does to the heart. So, efferent, there can be cardiac depression. Okay? I just want you to learn the afferent and the efferent. Now, this is what is, so we talked about oculocephalic reflex, here we are talking about oculocardiac reflex. Now, the question is, first of all, let me answer the question. Immediately stop the surgery. You don't want it to go into cardiac arrest. Okay, so we immediately stop the surgery. Now, coming to how to prevent it. To prevent it, first of all, whenever you are doing a squint surgery, we always give retrobulbar anesthesia. You all remember retrobulbar anesthesia? Behind the eyeball, it will block the ciliary ganglion. Okay, so this helps to suppress this reflex by blocking the ciliary ganglion. Where is the injection given in retrobulbar? What did we discuss? Intraconal space, right? Second, of course, it is risky. It can damage the nerves. You have to be very careful. But it is recommended that in squint surgeries, we give retrobulbar anesthesia. Second step of prevention is we give atropine. Okay. Other methods are also there. I won't go into details. Just we can give IM injection of atropine. So these are some important things which will, these two methods, these two means can prevent oculocardiac reflex. But still it cannot be 100% preventive. Any problem to the patient, please immediately stop the surgery. Right? So that was about oculocardiac reflex. From the ocular muscle, it is going through these nerves, long ciliary, short ciliary nerves. So यहाँ पे हैं these long ciliary. Mainly what you have to know, the afferent pathway is coming to the ciliary ganglion, then through the trigeminal, it is going to go to the trigeminal ganglion. From there, it is coming to nucleus, motor nucleus of vagus. Okay. Okay, so I think this is enough at your level to know about squint and things around it. Hope you enjoyed the chapter. Thank you so much. Stay blessed and keep smiling.